customized to individual body habitus. Gain and focus are automatically set, creating operator independence and repeatability. Proper positioning is necessary to help achieve high-quality studies. The patient lays supine. Towels, sponges, or pillows may be used to help evenly distribute the breast tissue and position the nipple pointing toward the ceiling. A thin layer of ultrasound lotion is applied. It is suggested to use a medical-grade spatula to assist in an even and light application. A disposable single-use mesh membrane is used to aid in acoustic coupling, compression, and stabilization. The arrow on the transducer helps with alignment and positioning. Gentle pressure is applied to evenly thin the breast tissue while aligning it parallel to the skin. The compression assist feature is used to set the pressure to one of 3 levels. Compression levels are adjusted while the patient breathes normally. The scan head assembly houses the exclusive 15-centimeter reverse curve transducer, which conforms to the female anatomy. With the touch of a button, the operator begins the acquisition. The transducer moves from the inferior to superior edge. Each acquisition takes under 1 minute. The typical Invinia ABUS 2.0 exam consists of 3 views or volumes. 6 volumes are required for a full exam, 3 per breast. These volumes overlap, allowing for additional coverage of the central aspect of the breast where typically the denser cone of breast tissue exists. Routinely, the volumes will include a centrally located anterior-posterior (AP) and AP projections of both the lateral and medial aspects of the breast. With intuitive graphics, users can customize protocols and take additional views for larger breast sizes and implants. For patients with smaller breast sizes, the acquisition can be shortened with the stop scan feature. After the acquisition is complete, a coronal view is displayed. The operator marks the nipple and performs a quality assessment review using either coronal or transverse data. The Cine review function can also be used to automate the review. The full exam is typically 15 to 20 minutes, which includes patient preparation and image acquisition. 3D volumes are sent to the Invinia ABUS viewer at the end of the study. The reconstructed 3D coronal slices allow for easy visualization of abnormalities on multiple views. Correlation with other projections and planes can be performed, and various hanging protocols, measurements, and image manipulation tools are available for thorough review and interpretation. The Auto Prior Compare feature mimics screening mammography workflow with the ability to save and compare priors for repeatable and reproducible longitudinal study comparisons. Invinia ABUS 2.0, helping physicians look differently at dense breast tissue.
Xin kính chào quý bác sĩ. Lời đầu tiên cho phép em xin phép được tự giới thiệu, em là Đỗ Thị Thu Hằng, là chuyên viên ứng dụng sản phẩm ngành hàng siêu âm TIA Box của G-Healthcare. Xin thay lời cho G-Healthcare, xin được nhiệt liệt chào mừng và cảm ơn quý bác sĩ đã bớt chút thời gian quý báu đến tham dự chương trình hội thảo khảo sát hình ảnh học ở phụ nữ có mô vú đặc. Đây là chương trình G-Healthcare tổ chức phát lại bài trình bày của giáo sư tiến sĩ bác sĩ Dr. Bản có kèm phụ đề tiếng Việt do Trung tâm Chẩn đoán Hình ảnh Bệnh viện Đa khoa Tâm Anh biên dịch. G-Healthcare mong muốn rằng Hội thảo sẽ mang những kiến thức mới và bổ ích tới gần hơn với những bác sĩ chuyên khoa tuyến vú của Việt Nam, những người luôn trăn trở với giải pháp toàn diện về sàng lọc, chẩn đoán và điều trị căn bệnh ung thư vú. Kính thưa quý bác sĩ, chương trình của chúng ta ngày hôm nay sẽ bao gồm 3 phần. Phần 1, vấn đề đọc mẫu ảnh ở phụ nữ có mô vú đặc. Phần 2, các vấn đề về hình ảnh mô vú đặc trong tầm soát ung thư. Sau chương 2, chúng ta sẽ dành ít phút để nghỉ giải lao, và trong khoảng thời gian này, quý bác sĩ có thể làm theo hướng dẫn để download cuốn sách Atlas siêu âm tuyến vú 3D tự động của giáo sư tiến sĩ bác sĩ Lobular. Bản đã được biên dịch sang tiếng Việt do Healthcare tài trợ bản quyền và biên dịch. Chương 3, chúng ta sẽ tiếp tục với chủ đề giải pháp sử dụng siêu âm vú 3D tự động ABOT trong thăm khám phụ nữ có mô vú đặc. Kính thưa quý bác sĩ đang theo dõi chương trình, MC xin 1 phút để giới thiệu nhanh về diễn giả của hội thảo của chúng ta ngày hôm nay. Giáo sư tiến sĩ bác sĩ Lobular là giáo sư danh dự Đại học Uppsala, Thụy Điển, giám đốc y tế danh dự của khoa X-quang tuyến vú Bệnh viện Parenchymal Central Hospital, Thụy Điển. Ông là một bác sĩ, nhà nghiên cứu và nhà giáo dục, người đã đóng góp đáng kể trong cuộc chiến chống ung thư vú trên toàn thế giới. Trong sự nghiệp gần 50 năm vừa qua, ông đã làm việc không biết mệt mỏi để giảm bớt và loại bỏ sự đau đớn, thậm chí chống lại cả cái chết cho các bệnh nhân của căn bệnh ung thư vú này. Nghiên cứu tiên phong của ông đã đặt nền móng cho việc phát hiện sớm thông qua sàng lọc mẫu ảnh hiện đại. Không thể nghi ngờ rằng công việc của ông với tư cách là nhà nghiên cứu, nhà giáo dục đã cứu sống hàng trăm nghìn phụ nữ trên toàn thế giới. Khó có thể kể ra thành tựu lớn nhất, nhưng những nỗ lực không ngừng của ông trong việc kết hợp các chuyên khoa y tế đa dạng lại với nhau để cải thiện việc tầm soát, chẩn đoán và điều trị ung thư vú đã ảnh hưởng sâu sắc tới các thế hệ bác sĩ chuyên khoa vú hiện nay. Giáo sư tiến sĩ bác sĩ Lobular hiểu rằng tiến bộ trong tương lai chống lại bệnh ung thư vú đòi hỏi sự kết hợp của nghiên cứu lâm sàng với việc đào tạo các nhóm chuyên gia. Và quý bác sĩ có mặt ở đây hôm nay để tiếp cận những phương pháp mới trong việc sàng lọc, chẩn đoán bệnh lý ung thư vú, cũng như từng bước trở thành chuyên gia trong lĩnh vực này tại Việt Nam. Một lần nữa, The Healthcare nhiệt liệt chào mừng quý bác sĩ đã tới tham dự chương trình hội thảo. Và để bắt đầu chương trình, xin kính mời quý bác sĩ đến với chương đầu tiên có chủ đề vấn đề đọc mẫu ảnh ở phụ nữ có mô vú đặc do giáo sư tiến sĩ bác sĩ Lobular trình bày. Xin kính mời quý bác sĩ theo dõi.
Good afternoon, good evening. As you heard, this webinar is going to deal with a very important issue that plagues all of us who are dealing with breast imaging, namely the problem of reading mammograms of women with dense breast. And I hope that I'm going to succeed to describe a solution of the problem. I'd like you to remember this very important sentence. Professor Blake Cady in Boston told this evergreen sentence, extremely important. Early detection and treatment of breast cancer in early phase is the most important control mechanism of breast cancer death ever invented. So why don't we just go out and do it? Save lives. Well, the answer is very simple. It's too complicated to find breast cancer early. Partly because of the heterogeneity of the normal mammogram. Partly because of the heterogeneity of breast cancer, the progressive nature of the disease, as well as the competing hyperplastic benign breast diseases. Unlike any other organ, as you radiologists very well know, there are 5 structurally different mammographic parenchymal patterns. If you really want to look at the BI-RADS classifications, I provided in relation to our 5 mammographic parenchymal patterns. What is the difference? BI-RADS is pattern reading. Our patterns are based on mammographic histologic correlation. We are going to talk about this a little bit later. Whether you are reading a mammogram, ultrasound, MR, any breast imaging, think about Bill Osler, who was one of the founders of modern medicine. Okay, more than about 100 years ago. But this is very important for you to keep in mind. You cannot be a very good radiologist if you don't understand the underlying pathology. I have a question. Is BI-RADS based on pathology? Basically, we are talking about screening. Both in screening as well as in clinical situation when there are symptomatic patients. Please note that most of the women do not have abnormality. And that puts the radiologist really in a difficult situation. So I would very much like to go through the basis of being able to read a mammogram, and later on, also automated breast ultrasound. Radiologists are usually scared away when you use the word histology. But right now, we are talking about three-dimensional histology. And that's easy to understand and actually very enjoyable as well. Really got to go back in to Ashley Cooper. He wrote his book in 1840. And he skillfully and diligently injected different color wax into the openings of the surface of the nipple. And you know very well that there are about 12 or 18 openings. Please look at the different sizes and the extent of the lobes. So one of the subgross elements of the breast under the skin is the lobes. That was the drawing of Cooper. 170 years later, this is our 3D histopathology. A galactogram is a great way of learning the details of a lobe. Please understand that although there are many lobes, they do not communicate with each other. They may interdigitate, but they don't anastomose. And if I turn this upside down, then you are going to see the main duct. Let me make a comparison with the trunk of the tree. The branches of the main duct and the branches of the tree. As you see, women don't need many ducts. Women need a lot of terminal ductal lobular units, just like the tree needs a lot of leaf. And these are going to disappear, atrophy. The ducts stay. More distended ducts may become skinny, but the number of ducts stay. This is wintertime. Let's assume she becomes pregnant. And springtime comes back. The TDLUs develop. Or takes hormone replacement therapy. That was the lobe. So it is so important that you are not alienated by the word histopathology. Yes, I understand that you don't understand the cells, the cellular details, because they are not even seen on any breast imaging. But 3D pathology is the basis of all knowledge. Here are the ducts and their branches, and here is, let's call the milk factory. lobules, or terminal ductal lobular units. We have written books, stereoscopic books. I hope one day you're going to be able to view these books as this person does. Through the stereoscopic glasses, you look at the stereo images and you understand the subgross pathology of the breast. The rest is easy. You just put an X-ray tube above it and you get a mammogram. Let's practice. The four basic building blocks are the following. Let's call it a lobule. The lobule has about 50 or 60 fingers. We call it acini or acinus. But the size of this is just about 1 millimeter, 1.5 millimeter. Now you're a radiologist. Put an X-ray tube above it. What do you think the image is going to be? It's a nodular density. Does it vary in size? Yes. But they are still 1 to 1.5 millimeter in size. And imagine that tiny little organ has 50 fingers. Because then it contains all those cells that produce the milk. Now, why can I distinguish one terminal ductal lobular unit from another on the mammogram? Because we have basic building block number 2, the adipose tissue, the gray or black radiolucent on the mammogram. If I exaggerate this a little bit, that is, make the size of the terminal ductal lobular unit larger, and we get the so-called adenosis pattern. Basically the same pattern, however, it is larger and the ducts are more prominent. So far we have been talking about 2 basic building blocks, and now we are going to talk about the third one. This is the milk duct, pleated, and it has a charming twist. Here comes the X-ray tube, and that's going to be a linear density and fat and linear density and adipose tissue and linear density. So we are managing basic building block number 3. Unfortunately, there is number 4 that makes the radiologist look like this. Why? Because it not only hides all the normal basic building blocks, but also hides the cancer. I cannot find, you cannot find this carcinoma. You might see the tip of the iceberg here. Nobody can find this cancer. And probably we see the tip of the iceberg here. So now if you operate with these 4 basic building blocks, you understand it's the pathology of the breast. Very quickly, the duct and its branches are linear densities. The milk factory varies in size, still normal. And then the supporting tissue, this yellow, is the fibrous tissue we radiologists dislike, because it hides both the normal and abnormal elements, and the fat, adipose tissue, that outlines them, we like. Comparison with plants and flowers is fabulous, makes learning much easier. So, here's a mammogram. I think I can read a mammogram. What would be this nodular, spherical, oval-shaped density? Of course, this is going to be the terminal ductal lobular unit. And what is this linear density? Like 2 pipes and the fat adipose tissue between them. Duct. This is how we teach colleagues to read a mammogram. And here's a poster. I think you should have a picture of this. That does it all. Now you understand the subgross anatomy of the breast. And so you can understand the mammogram, the MR, and ultrasound. Here is the MR. Does the MR show the terminal ductal lobular unit? Subsegmental duct? It should. If you have this MR quality, that is the high-res thin MIP, you see the duct, and another duct, corresponding to this. And the terminal ductal lobular units, corresponding to this. Very nice picture. So we understand MR anatomy as well. Do we have any other tool in the toolbox? Yes. The topic of today's lecture, ABUS, or automated breast ultrasound. Don't be surprised. This is not exactly ultrasound. Conventional handheld ultrasound provides a cigarette paper thin slice. Now, if you multiplied this 300 times, then you got a 2 millimeter thick slice. And that's exactly what is in front of you. So tell me what you see. You see the basic building blocks. Here's a terminal ductal lobular unit. Here is adipose tissue. Here is a duct. Here is the areola. And the tip of the nipple is marked. And so I look at these two first slices. It's contiguous tissue. Normal, normal, normal. But if you look at the third one, there is a defect. Now, screening is not diagnosis. But when you put the cursor here, you're going to find out that this is a cyst. Or it can be a cancer. You see the architectural distortion? You don't need to. You actually have to find this tissue defect. Now we cleared the basics. And what is the magical tool? Now, first of all, histopathology really has to grow into the 21st century. This small paraffin block, 1 by 1.5 centimeter, should belong to the past. The earlier the breast cancer, the larger the paraffin block should be, and it should measure about 10 by 8 centimeter, of which the pathologist or the pathology technologist can slice 4 micron, and that's what we call large but thin. Or, as you're going to hear a lot in this lecture, what if you slice 1,500, 2,000 micron? Then we are talking about 3D, subgross, thick-section histology. Right in front of you, this one is the large thin section, and this is the large thick section. It really shows you a duct as a tube, a cyst as a spherical cavity. Please compare the 10 by 8 centimeter to her palm. Taking a piece of tissue out of here, I'm not going to be able to make the mammographic histologic correlation. I don't want to have this cut up. It has to be large section. 3D histopathology we use mostly for teaching purposes. You put the paraffin block into an incubator overnight. Paraffin doesn't like heat, so it's going to melt. And so you got this tissue. And of course, it doesn't cost much to buy a sharp knife and trim it to 2 millimeter, 1.5 millimeter. and you stain it. Here is the end result. Now you can just lift it up and compare immediately with a mammogram. This is the nipple, this is the nipple. This is a retroareolar duct. And these are the retroareolar ducts. Have I learned something? Of course, bit by bit. So then we want to photograph this specimen. We pour methyl salicylate into the petri dish, put the tissue into it, and take pictures. Or, in order to teach the colleagues, we plastinated these large pieces of tissue. I have about 200 of them. My old-time friend Tom Stavros was visiting my department about a year ago. And please compare the tissue size with his hand. Well, he has a big hand, big as a spade. So now you understand what large section means. Instead of chopping it up into small pieces, and the poor radiologist cannot compare with his MR, ultrasound, or mammography. Here is an intracystic carcinoma. And this one is the intracystic component. And also this one is an intracystic component. Now you can see the feeding tumor vessels, angioneogenesis. You can see neoduct genesis occupying the central portion of this breast. Here is the skin, here is the nipple, here is the chest wall. Really, the major value of the large thick section histology technique is to bridge the gap between the cellular detail, which we never see on the mammogram, but we see structures. So when you talk with a histopathologist who only talks about cellular details, he really doesn't talk with you. We have to find out the structure. For example, here is an architectural distortion. Architectural distortion is extremely difficult for radiologists. Is this benign or malignant? Yes, I see a large radiating structure, and there is no or hardly any central tumor mass. It can be a radial scar, can be a diffusely invasive carcinoma, but as you learned it, you have to look for the black in order to see the white, the radiolucent. Now, if the histopathologist is going to give you these small pieces, you will never be able to compare with this one. But if I give you a large, thick section, then you immediately understand that this is a radial scar. What is radial scar? One of the hyperplastic breast changes where the ducts are proliferating and they are arranged in a radiating fashion. I learned it. Here comes the case. You see, this is the problem with current histopathology, that they only give you this tiny little detail and you learn nothing. Even if they give it 10 times, cannot put it together. I learned something. This is a black star. Highly likely it's a radial scar, and here are the cellular details. Instead of eliminating this and jumping from here to there, so the 3D pathology really fills the gap. Nothing is more beautiful on 3D histopathology than the radial scar. You see 4 different examples of that. Or here is a very extensive carcinoma. Here are the microcalcifications. This is very aggressive. This is a new vessel, angioneogenesis. Why is MR positive? Because this is porous, through which the gadolinium comes out. And this is going to be very positive on MR. Well, this is what we are going to, what we are doing tonight, and this is what we do when we teach colleagues. You can never, never be a good radiologist or an ultrasound or MR reader if you don't understand the underlying histopathology. They hold it up against the light. They look at it in the microscope. And they understand anatomy. And what is cancer? The distension of distortion of normal anatomy. You can understand physiology. These are the acini and the cells within that produce the milk. The baby is happy. This is what I call springtime. Very active breast. Proliferation, involution, proliferation, involution. And eventually, it's going to be just involution. And we understand how a dense breast becomes fatty replaced breast. Very beautiful organ. Even if it's not a six-section histology, you understand that these are the different size TDLUs. Unfortunately, a lot of connective tissue. Here is a duct, pleated duct. And here is fat. But of course, we radiologists understand 3D pathology much better. I'm building up all the way to evaluating automated breast ultrasound. Beautiful organ. You know now that fat, adipose tissue, fibrosis, ducts, and the most important basic building block with kind of varying sizes, the milk factory. When cancer develops, this tiny little finger, acinus, becomes ever more distended. This is carcinoma. This is normal. Look at the distension. Look at the distortion. And if we radiologists are lucky, we are going to see calcifications. If not, we are not going to be able to see the cancer. It's pretty unfortunate that the pathologists would call this ductal cancer in situ. I mean, already in 1976, this ingenious pathologist in Davis, California, described that ductal carcinoma in situ is actually of lobular origin. This is a lobule. And a progressive distension of the ductules, acini, as you see it here, with anaplastic, that's called cancer cells, are going to make the acini distended. And unfortunately, that's where the misnomer comes from. And they don't use large section. They think this is a duct. No, it's not. It's an acinus. So it's falsely appeared to be small ducts. Don't use the word DCIS. It's cancer in situ within a TDLE. Now, here is the biggest problem in reading a mammogram. There are the 5 different parenchymal patterns. One of them is dense, the other one is dense, the third one is dense, and we have to make a distinction. This one is what I call the springtime. Normal density, normal risk, and actually ever decreasing risk. Because when winter time comes, the risk of developing breast cancer is going to decrease. She becomes pregnant or takes HRT, springtime comes back. That's a very dynamic trio here. But this one, 12% of all women belong here, never changes. When she developed her breast, it was already adenosis, and it never changes during her lifetime. This one, about 5 to 8% of women belong here. I don't know how should I call it. I call it a joker. Actually, I don't know what's behind the dense fibrosis. It may be springtime, it may be wintertime, as you are going to see it when I show histology. Well, I personally dislike to harass women by saying, you have a dense breast, therefore you run a high risk of breast cancer, because this one, and this one, and this one accounts for about 40 to 50% of all women. You cannot imagine that every second woman runs a high risk of getting a breast cancer. That's not the point. And that's not the point of this webinar either. The point is that I'm missing the tiny cancer, which I very easily find here and here. But I might miss it here. I might miss it here. Every radiologist knows this problem. So let me detail very quickly the 5 mammographic parenchymal patterns by using the 4 basic building blocks. If you take just about equal amount of nodular densities, linear densities, fibrous tissue, and adipose tissue, you talk about pattern 1. You can call it BI-RADS 3, where you see the individual ducts and the terminal ductal lobular units. Small flowers, small TDLUs, nodular densities. You can read a mammogram. These are linear densities separated by adipose tissue. All of them are diligently pointing toward the nipple. And there are a couple of TDLUs. Can you see the linear densities? Nodular densities, adipose tissue. So you and me have to account for every single nodular and linear densities. If your colleague asks, what is this linear density? Then you could just refer to this picture. It must be a duct. And what about these nodular densities? By this time, you really know that these are the different sized terminal ductal lobular units where the milk is produced. Likewise, beautiful harmony. There is no nodular density, no stellate lesion, no calcifications that disturb this harmony. And I can sign a paper. It doesn't have demonstrable mammographic abnormality. Comparison with plants and flowers always helps in retaining this information. Pattern 1, and of course, this is the dream of the mammographer. Wintertime. The leaves are gone. Well, the ducts are there. That's the only thing. And of course, large amount of adipose tissue. Pattern 3 is kind of a little sister of pattern 2 that is up to about 25% of the breast. You see linear densities and then adipose tissue. What is this distended linear density? Do ultrasound. You are going to find out this is fluid distending the ducts. Now comes trouble. Pattern 4. Larger nodular densities, because instead of having 55 fingers, you have 120. So hyperplasia and hypertrophy of the terminal ductal lobular unit is adenosis, but also you see enlarged prominent ducts. This is adenosis. This is normal, and this is adenosis. Kind of a variant of normal. Now comes the joker. And this is what Biret calls pattern D. You see, this is very, very dense. But it's actually empty inside. It's atrophy. There are no TDLUs. Very few. But at the same time, it can be springtime. I don't know. Look at these thousands of TDLUs.
Kính thưa quý bác sĩ, chúng ta vừa tới với phần trình bày đầu tiên của giáo sư tiến sĩ bác sĩ Lobular với chủ đề vấn đề đọc ngũ ảnh ở phụ nữ có mô vú đặc. Thông qua phần trình bày đầu tiên này, giáo sư cung cấp cho hội thảo những kiến thức cơ bản từ nền tảng để hiểu về cảnh học mô tuyến vú, bắt đầu từ mô học cho tới 5 kiểu hình đặc trưng của mô tuyến vú trên ngũ ảnh. Đặc biệt, giáo sư cũng nhắc nhở chúng ta về những khó khăn mà quý bác sĩ có thể sẽ phải đối mặt khi đặt ngũ ảnh với các kiểu hình số 1, số 4 và số 5. Bởi ở những kiểu hình này, mô sợi tuyến dày có thể che khuất các cấu trúc phía sau, khiến quý bác sĩ không phân biệt được đơn vị tiểu thủy ống tân đang trong giai đoạn tăng sinh hay thoái triển. Và điều đó hoàn toàn có nghĩa có thể bỏ lỡ những tổn thương ở sau đó. Điều này chắc chắn sẽ ảnh hưởng không nhỏ tới kết quả sàng lọc và chẩn đoán ung thư vú. Vậy cụ thể, nó sẽ gây ra những ảnh hưởng như thế nào và giải pháp của chúng ta là gì? Xin kính mời quý bác sĩ tới với chương 2 của buổi hội thảo với chủ đề vấn đề về hình ảnh mô vú đặc trong tầm soát ung thư. Xin kính mời quý bác sĩ theo dõi.
So this is going to be the topic of this webinar after this introduction of technique and everything. We must not miss a cancer in these cases. And we do. We have, unfortunately, scientific evidence showing that we radiologists miss every third cancer, and they are invasive cancers. And I think it's a discrimination, unjust, against a woman who has a pattern 2 where she can rely my report. Trust. Everybody knows this. I'm not going to spend too much time. Sensitivity of mammography in these 3 patterns is much lower than in the others. I was mentioning you the 40 to 50%, but I'd like to be more specific. Based on 27,000 women's mammogram I classified, in age group 40 to 49, 100 minus 46, that's 54% have so-called dense breast. Age group 50 to 59, 31%. And mind you, for the rest of her life, 20% dense breast. Doesn't matter, 90 years old, 95 years old, he's going to have pattern 4 or pattern 5. So we will have problem in finding cancer early. Let me show you a very sad case, and I could ask you which breast is going to develop an 8 centimeter invasive, multifocal, and diffuse carcinoma. This is her mammogram about 39 months before diagnosis and treatment. Very dense breast, yes. And you signed a mammogram, normal breast. 18 months before diagnosis and treatment. Would you still find it? It's normal? Yeah, there is no dominant mass, neither circular or stellate. There are no calcifications. There is no parenchymal contour change. The no man's land is empty right behind the nipple. You don't see any abnormality. Medial half is empty. Are you sure she doesn't have an abnormality? You can never be sure. So then comes this. Still no dominant mass, no calcifications. Then you use the automated breast ultrasound, look at the multiple tissue defects, and you use the handheld ultrasound. And here is the MR. Now, this doesn't make any radiologist happy. You have many cases like this. I have many cases like this. And we have to change, which means that we have to set a stop of this discrimination. Pattern 2, pattern 3, perfectly reliable mammography report. Pattern 5, pattern 1, 4, 5. You don't sleep well. Look at this tragic case. And even more tragic is that they gave her neoadjuvant treatment, which delayed her surgery half a year or so. Not a single cancer cell died. Really, in the continuation, in the future, we have to strive for precision medicine. Try to find out by examining the 21 genes whether this is at all sensitive or not. She has undergone preoperative neoadjuvant treatment, but the cancer cells were viable in a 10-centimeter area. Here it is, a large section and the viable cancer cells. Not at all fun. So you see, these cases, not only anecdotal cases, but the scientific evidence I was mentioning to you, that we are missing every third cancer in these dense breasts. Results in interval cancers, results in harm for women. So we need multimodality approach. Screening. Mammography is not good enough. Yes, we have developed mammography and further developed. Nowadays we have tomosynthesis, which, however, unfortunately doesn't work in pattern 5. Our toolbox is full. Handheld ultrasound is a godsend, but in a population-based screening, you cannot use it for practical reasons. And there is the interventional tool, fine needle aspiration, larger bore needle biopsy, and so on. MRI is invaluable, but as a screening tool, this is what we have, automated breast ultrasound. So in the second half of my lecture, this is what I'm going to talk about, and you're going to understand why I was telling so much about the technique, about 3D pathology, and so on. Because this is not a whole breast ultrasound. Mammography takes care of the fatty replaced area. This is where we have the problem. And we made a mistake during the development of this technique because we kept the word ultrasound. This is not ultrasound. This is three-dimensional ultrasound. Should we have called it 3D sonogram? Sonographic CT? You yourself can help us in finding the proper name. Why am I saying that the handheld ultrasound examination is not suitable for screening? First of all, because that tool has never been designed and manufactured for screening. It was manufactured for diagnosis and differential diagnosis. And it's very, very good tool for that. However, it's operator dependent. There is no standardization ever. It really has to be automated breast ultrasound. Just imagine that a mobile unit is about 2 hours drive from you. You cannot have an ultrasound technologist examining, let's say, 80 or 100 women a day, every day, with handheld ultrasound. It has to be automated. It's worked out, and it's extremely patient-friendly and technologist-friendly. Here is the story. It's automated because within this compression plate, which is, by the way, curved, there is a 14-centimeter probe that automatically moves. Push the button, and then it moves in the direction you choose. And then the reconstructed images are going to be piled up over each other in the brain of the computer. But of course, you're not reading the cards or playing cards. The stack, you just place them out. This is the skin, 2 millimeter deep to the skin, 4 millimeter, 6, 8, and so on. I could ask you a question. Which one is the mammogram and which one is the 3D automated ultrasound? You can't make a difference. Courtesy the 2 millimeter thickening, a thick section. So these are the terminal ductal lobular units. This is a beautifully contiguous tissue corresponding to this pattern 4. But let's take pathology. I'm going to hide a 10 millimeter cyst in this breast. And because each slice measures about 2 millimeters, I'm going to find it at least 4 times. Because here is the tissue defect, and here is the tissue defect. And just like slicing a barrel, the first slice is small, second is larger, and then it's getting smaller and smaller, as you see it here. Don't try to make the diagnosis. Screening is not diagnosis. You call the patient back, you use the automated, the handheld ultrasound, and then you get the diagnosis. Here it is. And here is the corresponding histopathology. Let's hide a stellate lesion, measuring 10 millimeter, which I just missed on the mammogram in the dense breast. I should see it at least 4 times. And I do, because the central tumor mass punches a hole on the contiguous tissue. You're going to see it 4 times, 5 times. So you just heard how we are teaching colleagues to read the mammogram. Now we are going to do the same thing with automated breast ultrasound. The 2 millimeter thick section. Yes, this is automated breast ultrasound. This one corresponds to this, and this is corresponding to this, and this long one is this one. Indeed, this is ultrasound. Your other TDL use. And here is duct. So just imagine that the woman is either standing in front of you or lying supine, because ultrasound really loves to go through a thin tissue layer. In addition, we are going to compress. So what is the first layer? Well, it's going to be the skin, with the skin pores or sebaceous glands. What is this dark tissue here? Well, the areola and the fibrosis. Now we are going 2 millimeters under the skin. Everybody knows normal anatomy, right under the skin. It's adipose tissue. Adipose tissue. This is the mammogram. This is the 3D automated breast ultrasound, and here is 3D histology. Now we go further, deeper. I'm going to expect tissue and fat and tissue and fat It's like the Eiffel Tower. You're slicing deeper and deeper the Eiffel Tower. So where is the tissue? Right here. Where is the tissue? And among it, it's fat. 3D, tissue, fat, tissue. Here is the mammogram. Here is the 3D automated ultrasound. And here is the truth. Adipose tissue, fat, and fibroglandular tissue with its concave contour. Now we are going even deeper. Here it is on the mammogram. I'm expecting very contiguous tissue, TDLUs and TDLUs and TDLUs, no interruption, just by little amount of fat. And that's what we are seeing here. I hope it's understandable. Large number of varying size TDLUs here and there. And I'm right here with this section. Brilliant comparison. And of course, in between, adipose tissue. Is there any tissue defect? Nope, not in this case, but there is here. So here is the skin level, and as if it was a step wedge, you go down, down, down by 2 millimeter increments. 6 by 2 millimeter, I'm down at 12 millimeter. And here's a tissue defect. Is this a cancer or a cyst? Not my business. This is screening. I'm just saying, recall. Actually, I see 2 lesions here. I'd like to refer to recommended literature. We wrote a 3-dimensional book about it. 3-dimensional, that is, there are the stereoscopic glasses inbuilt. We wrote another book as well. If somebody is on this webinar from China, I can give you this in a Chinese translation as well. But here comes a tremendous present. We can send this to you. You don't need to write it down. There are 25 cases, extremely well worked up. It took about 2 years to produce these cases. Please go through all these cases. You're going to gain a lot of knowledge. So, how am I going to read automated breast ultrasound? Now, first of all, I have to know what I'm looking for. If I don't know what I'm looking for, I'm not going to find it. You know, breast cancer is the malignant proliferation of epithelial cells. They are either in the ducts or in the fingers, acini. Those that originate from the acini are either going to be ill-defined microlobulated tumor mass or stellate lesion. Unfortunately, pathologists call it invasive ductal carcinoma. They are right, this is carcinoma. But they are wrong, this is not a duct. So therefore, we call it acinar adenocarcinoma of the breast. We borrowed the term from the pathologist's description of prostate cancer. And of course, when it's originating from the duct, then it's ductal adenocarcinoma of the breast. So instead of talking about tubular carcinoma, lobular carcinoma, ductal, apocrine, and whatnot, I simplify things. Please look at a mammogram. We call it imaging biomarkers because it makes a difference where the cancer is originating from. The duct, from the TDLUs, or from the mesenchyme. The site of origin is important. Unfortunately, the tiny little organ that produces the milk actually produces most of the cancers too. About 75% of all cancers originate from here. And that's the success story of screening. Because we find the tiny stellate, the tiny circular lesion, we arrest the process, we prevent advanced cancer, and we save life. But setting off the remaining 25%, we cannot control. And let me talk about the acinar adenocarcinoma of the breast first. Here is normal anatomy. When in situ carcinoma originates from the terminal ductal lobular unit, and if you are lucky, then it calcifies, then it's the powdery calcifications or crushed stone-like calcification. We know this is a grade 1, this is a grade 2 cancer in situ within the TDLU. And when the basement membrane is dissolved, then we got the stellate lesion or the circular lesion. Colleagues, 75% of the cancers look like this. You and me can control it. This is the circular. This is the stellate lesion. We have to arrest it before it becomes 15 millimeter. There is no reason to stress the radiologist or sue a radiologist because they missed a 4 or 5 or 9 millimeter carcinoma. We can cure all of them up to 10 millimeter.
Kính thưa quý bác sĩ, chúng ta vừa đến với bài trình bày của giáo sư tiến sĩ bác sĩ Ultrasound. Chúng ta sẽ dành một ít phút để nghỉ giải lao và trong khoảng thời gian này, ban tổ chức sẽ chiếu một mã QR code trên màn hình. Quý bác sĩ có thể dùng camera của điện thoại để truy cập vào đường link cuốn sách Atlas siêu âm vú 3D tự động của giáo sư tiến sĩ bác sĩ Ultrasound. Bản đã được biên dịch ra tiếng Việt do G Healthcare tài trợ bản quyền và biên dịch. Xin nhiệt liệt chào mừng quý bác sĩ đã quay lại với chương trình hội thảo khảo sát hình ảnh học ở phụ nữ có mô vú đặc. Thông qua hai chương đầu tiên của giáo sư tiến sĩ bác sĩ Ultrasound trình bày, quý bác sĩ đã đi từ các nội dung vấn đề đọc nhũ ảnh ở phụ nữ có mô vú đặc và các vấn đề về hình ảnh mô vú đặc trong tầm soát ung thư. Thông qua hai chương đầu này, giáo sư Taba mong muốn mang tới cho quý bác sĩ cái nhìn khách quan và khoa học về việc khảo sát hình ảnh học ở phụ nữ có mô vú đặc. Thông qua việc cung cấp những kiến thức từ nền tảng mô học, giải phẫu học 3D, cũng như thông qua sự so sánh tương quan giữa hình ảnh mô học, hình ảnh mammo, siêu âm cầm tay và siêu âm vú 3D tự động. Vậy đâu sẽ là giải pháp cho việc sàng lọc chẩn đoán bệnh ung thư vú? Xin kính mời quý bác sĩ sẽ theo dõi phần tiếp theo, giải pháp sử dụng siêu âm vú 3D tự động ABUS trong thăm khám phụ nữ có mô vú đặc. Xin kính mời quý bác sĩ theo dõi.
I'm going to demonstrate the problem. Pattern 1. You see the carcinoma here? I don't think so, but it's there. Found by ultrasound. And this is what we call the iceberg phenomenon. Only the nose, the spiculations are sticking out. But it's so easy to pick up with automated breast ultrasound. Mammogram, I don't see it. Ultrasound, very easy. Don't even have to be a doctor. But here is the 3D pathology. You see how much of the cancer is actually hidden in the surrounding fibrosis. Here is another case. Good test for a radiologist. This contour is concave and concave and concave. Is this convex? Yes, it is. Right there. That's where the cancer is. But most of the cancer is hiding under the surface, as you see it here. Can I find it with automated breast ultrasound? With handheld ultrasound? No problem whatsoever. I had a problem here. I don't have a problem here. These are the acinar adenocarcinoma of the breast. Even worse, this one measures 22 millimeter. Any radiologist could pass by it easily. What if we are using ultrasound? No problem at all. Here is the tissue defect. It starts to die in the middle. You can expect rim enhancement on MR, but we are not screening with MR. We should screen with ultrasound. And of course, there is no mammographic abnormality whatsoever, but there is a cancer there, hiding totally in the surrounding tissue. And here is, in surrounding fibrous tissue. And here is her handheld ultrasound and 3D automated. It's going to be very difficult for radiologists to point out this contour change, especially if this mammogram is 1 out of 200 in your screening batch. But the cancer is there. Changing the contour. What would the automated breast ultrasound look like? Like this. And so case after case I can show you this. Then we arrive at the 20%. Now, this is not for ultrasound. Most of the cancers originating from the major ducts calcify. Calcification is for mammography, unless it's a non-calcified neoduct genesis. And then I would expect that there will be architectural distortion. And there is. And here comes the big troublemaker, 5%. Also known as invasive lobular carcinoma, but let me open your eyes. It has nothing to do with the lobules. It originates from the stem cells of the mesenchyme. They transform. Mesenchymal cells decide to become epithelial cells through transition, MET. And the result is an enormous amount of fibrous tissue proliferation. Now, that's good for ultrasound, but not for mammography. Here is an 8-centimeter carcinoma. Here is a 10-centimeter carcinoma, and here is a 7-centimeter carcinoma. Any radiologist could pass by it easily. But the architectural distortion is going to be seen on automated breast ultrasound. Just compare this, the mammogram with the automated breast ultrasound. And you may be very depressed if I'm telling you that every bit of radiopaque density here is carcinoma. Here's the proof. How are you going to find this? Not on the mammogram. Not at all. Handheld ultrasound and automated breast ultrasound. That's why we should really have this method in addition to fulfill digital mammography. Concave contour. No, this is what normal fibrogranular tissue looks like. No, this is carcinoma. It's all carcinoma what you see here. Concave contours, fooling the radiologist. Retracting the whole breast. Yeah, because the whole structure is diseased. Unfortunately, also, this one is stem cell carcinoma. We cannot find it early, and there is no cure against it. Sad story. Yes, we can control 75% of all breast cancers, not 25. These curves show that 30 to 40% of these patients are going to die from breast cancer within 10, 15 years. And in the past 60 years, these curves didn't change at all. Despite the development of breast cancer screening, despite the development of new therapeutic regimens. Sad story, but we have to live with it. So one of the questions was what to look for. I'm going to look for tissue defect and find stellate and circular lesion called acinar adenocarcinoma of the breast. I'm not going to look for calcifications, but I'm going to look for a huge ultrasound finding, the 5%. But the next question is, where? Is there any specific region in the breast where I should look for these? Yes. A woman is standing in front of you. Think about it. 80% of breast cancers are in the upper half, 20% in the lower half, leaving about 1 to 2% for a retroareolar region. But also, 70% of all cancers are in the lateral half, and about 30% in the medial half. Now I know what am I looking for. Now I know where I'm going to look for. Let's do it. I'd like to mention to you a very simple comparison. ABUS is taking 2 millimeter tissue slices. Now, I photographed a children's book, which has 2 millimeter thick pages. That's very comparable to reading ABUS. There are 3 acquisitions per breast. That means that you radiologists have to read 6 books looking for a tissue defect. Let's take the most troublesome, the Biorez D, the pattern 5. Homogeneous, ground glass-like, structureless. What's in it? Wintertime? Springtime? Don't know. Big problem. I don't see parenchymal contour retraction. I don't see bulge out. And I don't want to sign this. I need help. Now, help me. Please. Here's a case. Sad enough. 37. She herself feels a lump. Clinical breast examination. You feel it yourself as a clinical breast examiner. And you see nothing. And you ask for magnification. No mammographic finding. No tumor mass, no calcifications. CC projection. Then you use the 3D automated ultrasound that actually acts like a radar. It penetrates this homogeneous, dense fibrous tissue, and you find a filling defect. I mean, you find a tissue defect. And that actually measures 12 millimeter. I don't believe I felt 12 millimeter. I don't believe the patient felt 12 millimeter. And you know very well, when a woman under 40 feels a lump and it turns out to be a cancer, and it's most of the time multifocal and most of the time very aggressive. Where is the other one? Here. You see the ribs, you see the muscles, and this one makes sense because although this one measures 12 millimeter, the second measures 29 millimeter. Now, that makes no radiologist happy because I missed 12 and a 29 millimeter. Nobody can find it on the map. It's there. It's there on automated breast ultrasound, on the handheld ultrasound. And if it's multifocal, you can count on it. It already gave metastasis. You prove it. And you do a MR. Yes, there is very extensive enhancement. Nevertheless, it shows both of the cancers. And here is a disappointment. Now we have to do something about this. And that's what we call automated breast ultrasound plus mammogram as screening tool. 2 nodes are metastatic. You shouldn't go on like this. One more case on this virus, a D, 45 years old. She herself felt a lesion. Do you see it? Well, somewhere in this direction. Could this be this one? Give me ultrasound. And it's, of course, very simple to see. Dyes in the middle, shows that this is an aggressive, fast-growing carcinoma. Put the needle in. 1 shot is enough. Very aggressive, poorly differentiated carcinoma. Fortunately, unifocal. Here is the proof on MR. High-res MR. Upper outer quadrant. Unfortunately, had a very thin margin. You use ultrasound also on specimen X-ray. Here is the solitary lesion. Fully differentiated. Too large. Should have been picked up earlier. But there is not a chance for mammogram. For the mammogram, find it. Let's take one step back. Pattern 4. Bad enough. You know now what pattern 4 is. It's actually a harmonious pattern. So you have to spend a little bit more time to view it side by side, step by step. You got this information as well. And it doesn't change. It's a high-risk pattern. Actually, if you really want to talk about risk, this is the only pattern that is high risk. Not the 5, not the 1. Unfortunately, BioRisk does not distinguish this one from the others. Here is one, fortunately, the patient pointed out, the thickening here. Yes, it's visible on the mammogram, especially if somebody points out. But it's much easier on 3D automated ultrasound. Now, suddenly you see 2 defects. One of them is gray, the other one is very black. This one, the gray, is multifocal. Put the cursor there, obviously a carcinoma. Let me tell you, if it's very black, then it's very much possibly an air bubble. So this is artifact. But the MR shows that it's much more extensive disease. It's both multifocal and diffuse, which means double trouble. Multifocal AIBs and diffuse cancers harm women. And this was developing in a pattern 4. And this was not detected when it was 10 millimeter. Just very quickly moving towards the end, just in order to tease the poor radiologists, one of the breasts has an 8 centimeter carcinoma. Which one? Right or left? Not a chance. And so you do this. You have one tissue defect and you have another one. And you go on and slice, and it's still black, and suddenly becomes white. Why? Because this must be a cyst with the through transmission. So as long as you slice here, it's black. Now it's white. So this is not important. But this one is important. That's a huge carcinoma. I didn't see the cyst. I didn't see the huge carcinoma. I still don't know where it is. Handheld ultrasound, ultrasound-guided core biopsy, and MR shows very extensive cancer in the upper half of the breast. And if you look at the large section histology comparison, the whole upper half of the breast is full of cancer. And I didn't find it. Not fun. Not at all. I don't think we should continue with this. 8 centimeters. We have to do something about it. Now, the last one of the 3 dense breasts, BI-RADS 3, or BI-RADS C, and pattern 1. 72-year-old. I don't think anybody finds abnormality. This is an intramembrane lymph node. Not on the CC projections either. 2 years later, however, she develops a carcinoma. Where? Where most of the breast cancers are, in the upper outer quadrant. So I'm going to look at the lateral acquisition. Not immediately the AP or a medial. You find something else? It's very important. After having found one lesion, don't stop looking. Nope, I don't find anything else. So here it is. 5x2, about 10 millimeter deep to the skin. Yeah, right, when you compress it, it's about 10 millimeter. There you see the tissue defect, and then comes the handheld ultrasound, MR, one-shot core, we got a cancer. She developed a carcinoma. Are we done? Nope. She has another breast. Yeah, but the mammogram shows nothing. All right. What would you do? You would read the book taken as a lateral acquisition, and you find a cancer. It's not fair to treat her for the cancer in the right breast and let the cancer grow in the left breast. Is this a cancer? Yes, it is. This is in the right breast, and this is in the left breast. Benefit of ultrasound. Whether it is handheld, laborious, or automated. You see the carcinoma, about 10 millimeter. Now that's exactly when we should find the cancers. 9x8 millimeter, while the other one measured 14 millimeter. This 54-year-old woman felt a lump. Easy, you see it, palpate it, ultrasound-guided biopsy, fibroadenoma. Anything else? Here is the fibroadenoma. Nope, I don't see anything. Anybody can see anything here? Or 2 years later, the fibroadenoma starts to shrink. That's not an issue here. Mammogram still normal. Not very dense, pattern 1. But then the automated ultrasound finds tissue defects. 2. There is a satellite. There is a baby beside it. Look at this. This one and that one. Where was it? In the left breast. Left breast, AP acquisition. Let's go for handheld ultrasound, ultrasound-guided biopsy. MR, here is the larger one, and here is the satellite. Indeed, she has 2 cancers, and it was in the upper medial half of the breast. Here is the convex contoured lesion. You can compare, as you all of us should, with the 3D and the large section, thin section. Here is a carcinoma, and here is a baby beside it. Mammogram let you down. Automated breast ultrasound found it. MR found it. And we arrest the process. It was just about the time to do it because it's aggressive and fast growing. In addition, it also had DAB. That's why the small calcifications here. So actually, it's a very extensive disease. 23 millimeter, 6 millimeter, and a 6 centimeter cancer of ductal origin. I'm really moving toward the end of this webinar. Thanks very much for patience. But when this method was developed and we saw the potential, and I felt a déjà vu, back in the 1970s, when low-dose film screen mammography was worked out, science asked the question, so what? You move the time of diagnosis forward. You find it when it's non-palpable. Does it make a difference in outcome? And so here is this wonderful new method. As I showed you, hopefully convincingly, in many cases, we can find it when she already has it, but she doesn't feel it. So what, says science? So we simply had to repeat the story from the 70s. And it cost a fortune. My friend, Prof. Duffy, designed the study that goes down in history as SOMO Insight study. Published in Radiology. I'm just cutting very short. If and when we added automated breast ultrasound to full-field digital mammography, 26-27% more cancers were found. But then that was a multicentric, well-designed, perfectly carried out American study. The medical legal environment is different in America. So the callback rate was too high, questioning the acceptance of the method. So we ran another trial in Europe, and that's called the EASY study. In Europe, we have 2 to 3% callback rate. And imagine it only increased to 2.3%. And it found actually more cancers than the other trial. Now, this is why I'm saying, if we find 36% more cancers, if we add automated breast ultrasound to full-field digital mammography, then when we don't add this, then we are missing every third cancer. And that's not fair. So now we have a scientific evidence to the desire we always had. Let's have multi-modality approach screening. Then it's going to be fair to say the mammogram is needed for women with fatty replaced breast. And dear colleagues, this is exactly the story that should happen as soon as possible. She comes to the screening center, the technologist takes the full-field digital mammogram, had to replace. Thanks very much. Go home. Physician is going to read it, and you get a report. Now, what if it's pattern 1, 4, and 5? Then they take the mammogram, because ultrasound is not going to and should never replace mammography. Then, before she goes home, you should have also automated breast ultrasound. And that's going to be about 40% of all women. And that was the structure of these 2 trials, and this shows good example for future clinical practice. And there is hope, namely, I don't think the CAD is very successful in reading mammograms. But there is a CAD, FDA approved, that helps the radiologist who don't need to page through all the pages of this children's book. You just pick up the book, and this CAD is called See Through. So you see immediately the tissue defect. Just imagine, you just read the mammograms, dense breast, and now you open the viewing station and there is a black hole. And then you say, great, I'm going to call this patient back. It may show small, it may show multiple lesions, whatever. I hope that you understand that we are very excited about implementing this scientifically proven method in mass screening in the future. I'd like to conclude with Dr. Connie Jones' brilliant statement. Yes, we can be very happy that we have a toolbox full with fantastic tools. And the well-trained radiologist knows exactly when to use one or another one, because, as Connie says, we have never been in a better position in the entire history of medicine to deliver life-saving breast imaging services with a tremendously high level of quality as we can today. Thank you very much for your attention.
Kính thưa quý bác sĩ, phần trình bày vừa rồi của giáo sư tiến sĩ bác sĩ Larotaba đã kết thúc chương trình hội thảo khảo sát hình ảnh học ở phụ nữ có mô vú đặc. Sau khi chương trình kết thúc, ban tổ chức sẽ gửi bài giảng và link cuốn sách Atlas siêu âm vú tự động của giáo sư tiến sĩ bác sĩ Larotaba qua email cho các bác sĩ đã đăng ký. Với những bác sĩ đang theo dõi qua Facebook mà chưa kịp đăng ký với ban tổ chức, ngay sau đây ban tổ chức sẽ chiếu lại mã QR code một lần nữa. Quý bác sĩ có thể quét mã QR code để nhận được bài giảng và cuốn sách này. Một lần nữa, Ghi Healthcare chân thành cảm ơn giáo sư tiến sĩ bác sĩ Larotaba. Cảm ơn tổ biên dịch Trung tâm chẩn đoán hình ảnh Bệnh viện Đa khoa Tâm Anh, đặc biệt là sự theo dõi của đông đảo quý bác sĩ trên mọi miền Tổ quốc. Xin được kính chúc quý bác sĩ nhiều sức khỏe và thành công. Xin chào và xin hẹn gặp lại ở những chương trình tiếp theo.